Hey guys, let's go ahead and go down a particular case that came into my office recently. This is a young gentleman in his 40s who is extremely active in his life. He recently underwent cervical spinal surgery with an artificial disc replacement by another surgeon right here in the Valley. Artificial disc replacements are amazing when done right. And not to say this wasn't done right, but at the same time, I think there's some key lessons that we want to go ahead and learn from this surgery itself. The patient was still symptomatic, and despite multiple repeat diagnostic studies after surgeries, I think we found out what the cause of his symptoms were. His initial presentation was cervical radiculopathy. Again, if you've been following me on some of my YouTube videos, I always call cervical radiculopathy, which is nerve pain that travels from your neck into your shoulder and down the arm, depending on what nerve it is, the sciatica of the upper extremity or of the arm. So he was still very much symptomatic. In fact, he was so symptomatic, he was in the waiting room when I greeted him with his arm over his head, which is a normal posture for someone who's got a nerve that's really pissed off. First and foremost, though cervical disc arthroplasty or disc replacements are fantastic, it is a very nuanced procedure. It actually requires more time than a cervical discectomy infusion. The key to this is the fact that you never prize a latest and greatest or a sexy procedure or implant over neural decompression. The patient's pathology was a nerve being compressed, and if you cannot decompress that nerve, just putting in a great implant is nothing more than just technical work. There is nothing accomplished with that, and hence the patient is seeking out another opinion as to, hey, what are the next steps hereafter? The options were both not to his liking. Number one, we go back and remove the previous implant, go through all the scar tissue, and see if we can salvage a disc replacement with a different type of disc replacement. But more likely, the solution would have been, after doing a revision decompression, making sure that nerve is completely wide open, doing a fusion surgery. Cervical discectomy infusion gets a lot of slack because it's conflated with lumbar fusion surgery, which has arguably a very poor track record. And of course, Google and whatever search engine is full of that. But it really is one of our most successful surgeries when it comes to spine. In fact, some of my favorite surgeries are cervical procedures. The other option for this gentleman was going and doing a foraminotomy where we go through the back and try to create some more room so that nerve root that's being pinched in the front can kind of float backward a little bit. Not the most fun procedure as you go from a relatively minimally invasive anterior procedure to a muscle cutting, muscle destabilizing, or devitalizing, I should say, extremely painful recovery. So now that we've got the background to this, we're gonna go to my exam room, we're gonna look at the MRIs and the studies, and you can see how the shortfall of a great procedure can unravel it altogether. All right, guys, welcome to my exam room. This is where you would actually sit really literally next to me on this big computer screen, just so that you can understand what we're looking at. So going back to that patient that we discussed earlier, this is his CT scan. You can see at C6, C7 right here, there's an artificial disc replacement. So despite, I would say, very good placement of the artificial disc replacement, you can see right here why the patient is still very symptomatic. And I'm gonna blow this up here a little bit. It's a bone spur here. There's a bone spur coming off the actual vertebrae itself. And that's where the nerve root itself is getting pinched. In fact, it was never even addressed by the other provider. And for reference, you can see how the level above and the level below, you can drive a Mack truck to this area and you know that area is nice and open, all right? And hopefully you can see how this nerve root that comes out right here gets pinched from here, and it's got nowhere to go because there's a big bone spur here. If I wanted to be hypercritical of this as well, just to dial this down a little bit, are we seeing some evidence of loosening of this implant, osteolysis? And again, this implant has had case reports and case series of what they call osteolysis as well. So in any event, technique, the placement of this implant looks very good. But again, just because we put a great implant in or put a sexy device in that's the latest to the market, when you don't do a good neural decompression, the patient almost 8 months out is still symptomatic, right? So we can never prize a sexy surgery over what the goals of surgery are. The goals of any spinal surgery are decompression, right? And stabilization in the form of fusion or in an artificial disc replacement. You don't go ahead and say, I'm going to put an artificial disc replacement, and the decompression of a severely compressed nerve root takes the back seat, right? And at times, when patients come to us, we're kind of put in a corner going, hey, I don't think this is a good surgery for you, but that's better than a patient coming and having this outcome where 8 months out, an active, coach, if you will, is unable to even conduct his activities of daily living, even sleep, without relief of the intractable arm pain that he has. So this is the what they call the sagittal view, where you cut the spine in long pieces, right? Same thing is here on the axial view. If you're looking down the spinal canal, this is where the nerve gets compressed severely on that side. This is the bone spur. Now, again, the trepidation may be, should we go out this far along because there's a blood vessel here? I don't know what that was at game time during surgery, why the surgeon couldn't decompress this area. So the options for this gentleman are a posterior foraminotomy. So this is the back side of the spine, that's the front part of the spine. So where the nerve is coming out, we go ahead and cut through, we make an incision through the back, we drill out this bone spur right here in the back, which allows the nerve to kind of expand backwards a little bit. Of the hundreds of posterior cervical surgeries I've done in my career, I've always found these to be the most unpleasant just because the recovery for these procedures are just not fun. They're actually even less fun than posterior lumbar fusion surgeries. The patient is still wanting to preserve his range of motion, and therefore this posterior surgery is definitely an option. But what we have in store for him will be going through the front again, taking out the previous implant, drilling out this bone spur right here. If I can draw a line here for you, taking out this piece right here is going to be the goal to go ahead and address the pathology head on. Once you take this out, this area will be nice and wide open. And with that, if in fact we can still preserve his range of motion, we will choose a different type of disc arthroplasty device, as long as we have good bone stock, and likely use a keeled implant, which will provide much more stability than the current one. But again, I think there's ways to accomplish this, and ultimately the goal of today's video, or the message, is, neural decompression should never take a backseat to the latest and greatest surgery.